So we're going to go on a journey. I know certain people in the audience looking at one in particular, or, you know, might get involved in some audience participation. So just a point of note, this is a public lecture, so not everybody obviously is from an imaging background. So we're not going to be too technical, we're not going to do a huge amount of like physics, dare I say. And we will obviously show pictures, but I'm not going to go into any detail about any particular part of imaging, except, what do you think? I'm looking at you, Di. What? I'm going to talk mainly about ultrasound. It's an ultrasound machine.
Oh yeah. Wrong glasses.
Okay, I'll let you on. So, I know this will be quite basic for many people, but clinical imaging is really one of the cornerstones of contemporary medicine because diagnostics is front and centre. We hear about it all the time. We spend a lot of time, don't we, talking to the Department of Health and various people in the government. And actually the Society and College of Radiographers do say that in the NHS, around about 95% of patients in a hospital will be experience the imaging department in some shape or form. So I wanted to just talk about what we do. This is very superficial. We do a lot more than this. But we are involved in detection of, call it pathology, whether that be pathology or trauma. And what I'm showing you here, most of you will recognise, is a really rather nasty fracture of a right leg. So we do a lot of work in trauma, obviously. And also in detection of pathology. So here we've got a chest x-ray. This is the same one, but there's a nodule in this chest, which I've highlighted here. And that was a lung cancer. There's a lot of work now being done on treatment, what's called interventional radiology. And we have the radiologist training programme linked to the academy. And it's quite a favourite of the trainees now. They all want to be interventionalists. It's kind of like a form of surgery. But we only have 6 training places a year in the Northwest for this specialty. So it's highly, highly competitive. And just to show at the most basic sort of level, this is a blood vessel, and you can access an artery like this using what we call a catheter, and this is a vessel that's narrowed. And you can send this wire and catheter up, get it past where the narrowing is. And this is just an example of a technique where they've used a balloon to widen it, and then the vessel's open again and you get the blood flow going through. So that, as I say, is a basic type of treatment. But something that we're getting more involved with is disease management. Many of you will be familiar with the breast screening programme, for example. And Carol and I are doing some work at the moment. We've been asked by the Cancer Alliance to look at setting up a liver surveillance programme for patients who are at risk of developing a hepatocellular carcinoma who've got chronic liver disease. So that's the training programme that we're looking at. And this is an ultrasound scan of a liver, and I'm sure you can see that dark area there, and that's an actual hepatocellular carcinoma. So as I said, we're going to go on a journey. It'll be very rapid because we're going to go from 1895 to today. So I'm only going to be able to talk about things very briefly, but I'm hoping to sort of celebrate the milestones that have happened that have brought us to where we are today. The other thing I should say is that I hope you'll see as we go through this that a lot of what's happened in imaging has happened in the UK, and I don't think people always appreciate that. And there have been some Nobel Prizes awarded for some of the work that's gone on. And the period of sort of like 60s, 70s, 80s, where we saw the advent of ultrasound, CT, MR, are often referred to as sort of the golden decades, where imaging really took a massive stride forward. And as I said, I will talk more about ultrasound than anything. I can't profess to be an expert in CT, MR or anything. Ultrasound's my bag. We tend to have an area of expertise and we stick with it. And I have to acknowledge GE Healthcare. They've sponsored me throughout my career. They give me equipment for nothing. And like Denise, who's a friend of mine, we've run so many courses, haven't we, with GE? They're very generous. And that's a picture of a beautiful baby who's about 13 weeks old, and it's been done on a very recent piece of their kit. So, back to the beginning. And without this man, most of us in this room and online wouldn't have a job. We wouldn't have a radiology department. And in 1895, Röntgen, who was a German physicist, was doing some work using the tube in the centre. And that's a photo of one I took at the Science Museum. I have spent a lot of time in the Science Museum because I'm a nerd. And it's what's called a Crookes tube. And it's a vacuum tube, basically. I won't bore you with the physics, but he was doing some work on his interest was phosphorescence. And while he was doing this work, he had all his equipment laid out on his lab bench. And one day, and I couldn't find why this happened in any of the literature, but he saw like a flickering skeleton on a screen nearby on his lab bench. And Röntgen, being Röntgen, took himself off to the basement of his house and allegedly was down there for about 6 weeks, being fed and watered by his wife, and appeared thinking, I found something here. I don't know what it is. Some kind of ray. So he called it X-ray, X being the mathematical symbol for unknown. And we still use the term now, X-ray. So, very clever guy. When he reappeared from the basement, he managed to persuade his wife, Anna, who's up there, to take an X-ray of her hand. And that is a copy of the first X-ray that was really ever taken. And I was saying to the radiographers in the room, if you did that now, what would somebody say to you?
Do it again.
Do it again, because? Take the ring off. Yeah, you never X-ray anybody with any jewellery on. But you'll see a lot of rings on some of these early pictures. Now, what I don't think many people realise is that Liverpool played a really big part in the development of radiology. And Di and I worked together for many years at the University of Liverpool. And some of the images I'm going to show you, we actually found in the Pigeon Loft in the Department of Radio Diagnosis in Liverpool, in all seriousness, so you'll see a few of those. And there were two people, some of you may know of Oliver Lodge. He was a very famous physicist from Liverpool, and he got together with Mr. Robert Jones, an orthopaedic surgeon. And Robert Jones was very famous as well. He has a hospital named after him. He's had various medical devices named after him, like the Robert Jones splint. So they got together and thought, well, these X-rays, might have an application. So Mr. Jones had a patient sent to him, and this was the first case report that was written about the use of X-ray in finding a foreign body. And it was a 12-year-old young lad from Liverpool, and somehow or other had managed to shoot himself in the hand. And there was a piece of lead shot or a bullet stuck in his hand. So they did the X-ray. This is a copy of the X-ray, and I've circled there. I hope you can see the bullet. It's sort of the base of this third metacarpal in his hand. And that was done on a glass plate. And we were chatting earlier, Di and I, and there's still quite a lot of glass plates from these original images over at the University of Liverpool in the archives there, and they're fascinating, aren't they, to look at. That was one as well that was done in America around a similar time. A bit of an obsession going on with lead shot, I don't know why at that point. But within sort of 6 months of 1895, when he discovered X-rays, they were starting to use them on the battlefield in different wars, and they were being used primarily to identify foreign bodies to help the surgeons take them out. Before imaging, there was a technique which is crudely referred to as dig and stitch. So they had to try and work out where a foreign body was, because you had no image guidance, and that obviously required much more extensive surgery. Whereas in this young man, they were able to go in a much smaller surgical field and get the bullet out. So, and that still happens a lot today with foreign bodies. The other guy who was very well known in Liverpool is Charles Thurston Holland. He's an interesting character. He was a GP, and he got wind of all this stuff going on with X-rays and imaging, and he thought, I wouldn't mind a bit of that, I'm quite fancying that. So he jumped ship from general practice and started to take an interest in radiology, as it's called now. And in 1896, or only a year after the discovery, he took on a role as an honorary radiologist at what was the original Royal Liverpool Hospital, the one before the one that was recently demolished. So, and then after that, he took up a substantive post as a radiologist at Liverpool Royal Infirmary. And a few of us used to, I could look at 3 people who used to work in this building, and he worked out of there as a radiologist. And if you took a stroll down Rodney Street, there is one of the blue plaques that celebrates his input into radiology locally. So yeah, a lot to be proud of in Liverpool and radiology. Hands up if you worked at the Southern Hospital. So it's a real claim to fame, this, because it was known to be the first X-ray department in the country. And also there's still a query that's not yet really gone either way as to whether or not the Southern was actually the first X-ray department worldwide, but definitely in the UK. A lot of strong evidence for that. And I managed to find a picture of it. It was on Carroll Street down by the docks. It's not there any longer, but Thurston Holland worked out of there. That's a hand X-ray that he did, and again it's got a ring on. And what I've circled there is what's called the exposure time. So when you do an X-ray on somebody, you put down the film or whatever you're going to do the X-ray on. It's not film nowadays, obviously. You put the body part on top of it and you shine the X-rays through. But you'll know if you've ever been for an X-ray, they tell you to keep still. Hold your breath, keep still, whatever. And the exposure time to do that hand was 2 minutes. So you can imagine having to sit still for 2 minutes. And actually the exposure for some of the bigger parts of the body, like spines, abdomens, could go into hours while they were breathing. And if you move, you get what's called partial, isn't it? Motion unsharpness, is that what it's called? And you get a blurred picture like you do in photography. But again, this is one of the things that we found in the pigeon loft. And that's an elbow X-ray. And it's done in the same way that you do them nowadays. Same projections, like this and like this. That was a very good position to find it, because I'm looking at Tom's face like, Julie, don't do that. But actually, I've got an X-ray here. And this is one from a couple of weeks ago where, unfortunately, somebody had had an accident and they dislocated their elbow. And for those that are not imagers, you can see the humerus here at the top, like that, and the bone should be like that. But these bones are way out of place, and this is really quite a nasty injury. But actually, this X-ray that was taken in around about 1930 is not bad. I know it's not as good as what we have now, but it's not bad, is it? This is me in the Science Museum again. And I took this picture a few years ago. And this is an X-ray room from the 1930s. And actually, it's not much different in the setup to what we have now. You have a radiographer hiding behind a screen, of course. You've got a stand, somebody having a chest X-ray, and an X-ray tube over there. It's just that's what we have now, isn't it? It's just exactly the same, but a much older version. I found that quite fascinating. And some stats as well. So as imaging started to take off in 1913, so we are not yet 20 years in from the discovery. In Salisbury Infirmary, there were 248 X-rays taken. I couldn't find out what they were. But by 1919, there were 1,073 X-rays, so you can start to see that it was becoming really quite popular. But what they hadn't realised at the time is that X-rays are actually quite harmful. You can't set foot in a radiology department anywhere in the world without seeing so many of these signs, can you? We are required to display them by law. What they didn't realise was that there were negative effects from these marvellous X-rays. And in the diagram I've drawn there, that's really to say that they grew exponentially. Nobody thought that they were harmful. They thought they were similar to light. They were invisible. They were not you couldn't detect them by any senses in any way. So everybody just went wild, and they were X-raying everything and everybody. They soon realised that X-rays could cause harm. And again, that's a photo of burns, radiation burns from 1900, of a technician who you might have been like an early radiographer. So then they started to think, actually, these X-rays are not as safe as they were thinking, that they could cause harm. And they soon started to think about, and I'll talk a bit more about this, how they could reduce the harm to the patients. And they started to think, even this early on, well, actually, it takes us a long time to make an X-ray. And if we could shorten the length of time it takes to make an X-ray, maybe it might not be as harmful. And as I say, I'll come on to that. But you often find in science that things run in parallel. And as they were thinking, well, these X-rays are harmful, then there was this electrotherapist in the States called Grube, who actually thought, well, actually, if they're burning things and doing harm, maybe they could be used for treatment. And they were the first people to actually write about sort of like an early radiotherapy for a patient with recurrent cancer of the breast. So it was as early as 1896 when you might argue that they were starting to realise that X-rays might have a palliative effect as well. And I found this picture of the former Queen Mother, again in the Science Museum, and that was in 1950 with one of the very early radiotherapy units. Now, I'm not trying to scare people who are not from an imaging background here, so we do this with a bit of caution. And every time we take an X-ray, we're all trained to think there is a risk. That risk is very small, particularly nowadays, but there is always a risk of inducing cancer in a patient, as well as some other effects that we won't talk about. There's all sorts of things that are written about that, and you can work out radiation doses and all of this kind of thing. And I was speaking to our medical physics colleagues who support us in a lot in the Northwest, and they were telling me that the current estimate of induction of cancer from a chest X-ray in today's world is about 1 in a million. So every time you press a button, you've got a chance of inducing cancer, but it's 1 in a million. I wouldn't want people to think, oh God, I've got an X-ray tomorrow, I better not go. That's not what this is about. Because you'll get more dose from flying across the Atlantic in an aeroplane than you will from a chest X-ray. So you have to keep it in some kind of perspective. And the way that we do that to protect anybody who's a patient is by what's called a risk-benefit factor, where you think you get a referral and you have to weigh up whether or not you're actually going to do it. So I'm going to do a chest X-ray, I'm going to do a CT scan. And we are required to think like that. So you have to, when you get a request, say, what's the likely benefit to the patient? And I have to weigh that up against the risk. And sometimes you think, actually, that risk can't be justified. And then we go and speak to the clinicians and say, look, can we do something else? We might change to something like an ultrasound machine, which is a bit safer, perhaps. But we always have to do that. And the reason being that all imaging departments have to comply with the ionising radiation regulations, and all of our staff have to be IRMA trained so that they can weigh up risk benefit and do their work when it uses radiation in a safe manner. So moving on, as I said, we want to reduce the effects of radiation now because we know it's harmful. And we've gone from it being long exposures to nowadays it's milliseconds. And that's helped. Hands up if you remember Kodak. So in 1918, George Eastman in America was doing a lot of work with film and photography, if you know about this. And he set up Kodak, and we've used Kodak in imaging for many years. And he started to wonder whether or not there would be a role for film rather than glass plates in getting images. And he was right. We started to use film. So we've gone from the glass plates to, this is one of the first X-rays that was taken on film, and that's a lemon sole fish. And the image quality actually isn't bad. But they were film, and like photographic film, you have to process it. At that time in X-ray departments, it was what was called wet processing. People had to move films, lots of nasty chemicals around. In a dark room, and you had a dark room tech, and often it was a student radiographer who got put in there as well to move things along. And as many of you know, images were displayed on a light box. Spot the deliberate mistake.
On the left side.
It starts back to front, yeah. So this is from Holby City. Those of you that watch Holby City, watch out, because a few of us message each other when things like that are on and go, oh look, that's X-rays back to front. So we've got now from glass to film. We still need to get the radiation dose down. So this is a cassette. I couldn't find out who actually first sort of thought about this, But what happened is you get the X-ray film, you put it in here, and it's got this these screens in it. And these screens, when you X-ray them, emit light. So if you look at my diagram I've drawn, you've got the cassette, this orange thing, with this intensifying screen in, and a patient here. You shine the X-rays through the patient, it hits the cassette, and this screen emits light. And it's that exposes the film. It's not the X-rays anymore that directly expose the film. That was a big step forward because it meant that the radiation dose would come down quite a lot, and it actually did. So that was a game changer. People then thought, well, what about fluoroscopy, as we call it? So might we be able to use X-rays to look at sort of function and movement in the body? That's a fluoroscopy suite, and that's almost like a mini operating theatre, if you like, if you see it in real life. And fluoroscopy's been used a lot for things like barium swallows, barium meals. That's a barium enema, and again, for the non-imagers, you can see the patient's rectum here, and this is all large bowel, which is filled with barium and air. But we get mobile versions of these, and the orthopaedic surgeons will be lost without them. And this is a mended fracture of a left lower leg, and the radiographer would be in theatre with a mobile version of one of these, and that would guide the surgeons in the placing of that plate and the screws as well. So still something that's used a lot. But in the early days, they used what was called direct fluoroscopy. And throughout the rest of the talk, I'll give some sort of like stories from my career. And this horrified me when I found this, because this is a radiologist in the early days. And this was around 1909. Didn't really understand radiation protection. So they were X-raying this lady, and there was a screen and held it, and you could see through it. But those X-rays are going through the patient, through here, and directly at him. Clueless, didn't know. And they carried that on for quite a long time. And when I first went to work at Salford Royal in the 1980s, I was very fortunate to work with a radiologist called Dr. Roland Wood. Some of you might know him. He was in his 70s at the time, and sadly he became really quite poorly with thyroid cancer. And I was talking to him, I used to go and sit with him on the ward, and he said to me, I've got this because I did so much direct fluoroscopy, because the X-rays were going at his thyroid gland. So again, a misunderstanding that X-rays were not safe. Now, I can't profess I know very much about nuclear medicine at all. It's a bit too clever for me, a bit like MR schooling. So I didn't want to leave it out, particularly because Andrew Tootle, who works with me, he's a big nuclear medicine person, so he's our nuclear medicine expert. But Henri Becquerel from France in 1896, so again, similar time to Röntgen, discovered uranium. And then the Curies, who were very famous in radioactivity, also started to get on that bandwagon, and they identified polonium and radium. And some of you who know anything about radiotherapy will know that radium was used a lot in the early days of radiotherapy. But that's a modern gamma camera. You lie the patient on the table, and they're usually injected or with an isotope, and the images are formed. And I'm just going to show you a sort of difference in the images. This is a 1970s bone scan, and you can see these areas that are dark are where the isotope's been taken up, and it's excreted here via the bladder. And this is one that's been done quite recently that was in a paper. And I said I would talk a bit about AI in this talk. This is a bone scan that's been run through AI. And the green squares are where it's identified bone metastases of secondary disease in bone. And when they showed the same images to a radiologist, they actually agreed. So, you know, there may be a role for it. And it's moved on a lot since then. I can't talk too long about things like PET scanning and stuff, but things are really, really going great guns in this particular area. And that's a PET CT scan. It's like if you've been cut here, and you can see these areas which are actually liver metastases, which are almost like lit up because of the procedure. So nuclear medicine doing very well at the moment. Now, I said I'd spend most of my time talking about ultrasound. And ultrasound constitutes about 30% of all medical imaging worldwide. We're at a crisis point, aren't we, in the UK with ultrasound. The numbers that we're being asked to do have gone up a lot. We don't have the workforce to do them. So we spend a lot of our time trying to resolve that problem. And it's not easy, is it, at all? But we are trying our very best. And whenever I get new trainees in ultrasound, I talk to them about sort of pros and cons, and remembering x-rays are known to be harmful. So ultrasound, my baby here, I don't go anywhere really without these things. And it doesn't use ionising radiation, it uses sound waves. So it's been proven for years that it's safe, it's been used for a long time, and there have been no deleterious effects. It's very good for soft tissue imaging, so it's good for organs, it's good for muscles and so on. But it's also cheap. These are much cheaper to buy than an MR scanner or a CT scanner. And the cost per scan is much less for ultrasound than it is for CT or MR. Probably about maybe a quarter of the price. And I've put readily available in red. You can see I brought my pal here. I just put it in a bag, put it in my car, and it can go anywhere, which is great. They're not actually, this is quite a big one, but some of them that we have are much smaller. They're actually like laptops. And they're good because you can take them to things like the emergency department or intensive care, where you can take ultrasound to the bedside rather than trying to get the patient to come to us. But it's not all good. It's rubbish at bone. Now I managed to, we did this with one of the high quality machines, and we were able to produce this rather beautiful picture, and the arrows pointing down are the surface of the bone in somebody's forehand where the radius is. But you can't see deep to the bones, you wouldn't be able necessarily to see a fracture or anything. So we use it in musculoskeletal, but not for bone. You can see muscles and tendons very well with it, but that's about all it will do. But yeah, back to readily available, and I'm going to get on my soapbox a bit now. And I know some of my ultrasound pals are online as well. They've become so readily available, you can get them that are like iPhone size, fit in your scrub pockets. It's a little transducer. The images are actually really quite good. I did some of the first testing on those when they came out. Why am I bothered? These are my ducks. I've had 5 ducklings this morning. I woke up and there were 5 new babies to this duck who's called Dottie. But the little girl there, but the reason I put that up is I always show that because you get people who are called what dabblers, we call them, and that means I'm going to have a bit of a go. That's dangerous, trust me, as you'll hear. And I've talked at so many conferences about you've got to be trained properly, and we set up, as you heard from Claire, the first training programme, which was actually in Liverpool. And I'm very, very keen on training. And you need to avoid the likes of this young lady, who is my daughter, Abby, who many of you will know. She's a lawyer. You don't want to come by a lawyer in medicine, really. She's actually an employment lawyer, and she's not here tonight because she's actually in court in Manchester. But I've used that as my prompt to talk about this. I've done a lot of medico-legal work in ultrasound particularly, and there was a particular case, and it related to the dabbling, and it was very serious. A baby was born with severe cerebral palsy. I haven't time to go into the story, but something had gone wrong in the management, and it was to do with somebody having a go at dating the baby using ultrasound. We didn't know what they were doing, and the baby was got out at the wrong time when it was too early. And it was catastrophic. There was, I think off the top of my head, I remember it being a £1.8 million payout. But I had to go to court, and it was in the Royal Courts of Justice in London, Court 1, which I'll never forget. I'm actually quite a confident person, I think, but I was terrified, absolutely terrified. And I was asked to go and speak a lot afterwards about my experience in giving advice to people on medico-legal stuff. And I did one talk, and I was saying, and I was terrified, and I had to walk from the gallery, and you had to walk round in front of the judge. And I said, I finished up in the dock, and not in the witness box. And I've never, ever lived that down. Anyway, I don't know if you're aware, but ultrasound was first identified in bats, and that goes back to 1794, which is actually quite amazing. I won't tell you the the story behind it, because it was really bad mistreatment of the bats and how they work this out. It was quite horrendous. But most of you will be familiar with sonar, and ultrasound works on the basis that we have one of these things, which is poshly called a transducer, and it sends out sound, which reflects off something, it listens to it, and it makes a picture. And it's not actually any different to sonar that you get on a ship, which detects the depth of the sea floor. And sonar was used a lot in World War I for detection of submarines as well. So again, it was science rather than medicine that drove this. And in fact, these ultrasound transducers work on what's called the piezoelectric effect. And again, I won't bore you with the physics of that. I could if you've got like 3 hours, but I won't. But interestingly, it was the Curies again, 1890s, who first identified the piezoelectric effect that we use on a daily basis in that machine there. That's quite incredible. So every one of these ultrasound probes, transducers, has, sitting behind this grey bit here, has a series of things that the Curies use. We call them elements or crystals, and they're the things that help make the ultrasound. But it goes back to 1890. It fascinates me. The other thing that fascinates me is how do people think of something? So this is a guy called Theodor Giesecke, and he was a dentist actually from Vienna, and he was interested in neurophysiology, and he was really fascinated about how he might be able to detect brain tumours. If he'd have talked to me now, I would have said, don't bother mate, because it's not going to go through bone. But anyway, he didn't know that obviously at the time. And he built this machine which he called a hyperphonogram. And he got patients or some willing volunteer to lie in a bath of water, face up, so the back of the head, all their head was in water apart from the face so they could breathe. And he fired ultrasound through, and he got some, they called them images. To be honest, I'm not convinced. I still can't fathom out. But he was trying to say that these signals represented parts of the brain. Well, if you work in an imaging department, you'll know the term eye of faith, which means I think I can see something, but I'm not sure. Good point there to sort of give up and do something else, and not try and guess. But then soon after that first attempt with the spectra, he tried to produce a picture, and this is actually an anatomical drawing of the ventricles in the brain. And he says that this was the ventricles. And I think if you look back and squint a bit, you can probably see it. But, you know, I wouldn't put my name to a report based on that, that's for sure. But he was really one of the founders for ultrasound. But these are 3 people who are very, well, one in particular is very dear to me. They're called Donald, Mattvicker and Brown. And ultrasound, clinical ultrasound, was really pioneered by these 3 guys. And Ian Donald on the right was an obstetrician in Glasgow. The man on the left, John Mattvicker, really lovely man, also was an obstetrician and gynaecologist, and the person who I hold dear in my heart is this man, Tom Brown, who was an engineer in Glasgow, and he worked for Kelvin. And somehow or other, these 3 guys came together, and Ian Donald was really keen to see whether this technology of sonar could be applied to pregnant women. So sort of the start of ultrasound as we know it today. And if you look at this picture, this is the first, what was called a bedside scanner. And Tom built this. And this is a table, you know the tables you have in hospital where you pull them across the bed and you put the water on and people eat the dinner? That's it. It's called a bed table scanner. And they made an ultrasound machine out of it, and that was all down to Tom. And they had a patient, Ian had a patient sent to him who had a abdominal distension. She swore blind she wasn't pregnant. So he scanned her, and it resulted in this paper that was published in 1958 about use of ultrasound for diagnosis of abdominal masses. That picture, this one, was given to me by Tom. Again, if I had to say, is it an ovarian mass, I'd probably go, I'm not saying anything, because I just don't know. And I just wanted to compare it to one of my pictures that was done not that recently ago. And this is an ovarian mass. You can actually see detail, you can see cysts, put Doppler on and you can see blood vessels and so on. But apparently when they took that patient to theatre in 1958, it was an ovarian mass. Could have been 50-50, but it couldn't have gone either way. But nonetheless, these were true pioneers. And just a bit of a story about Tom. I first met Tom in the early 90s, and I was doing a lot of work for who Claire mentioned earlier, the British Medical Ultrasound Society, and I eventually became president in 2008. And I was very fortunate to be introduced to Tom. And when I was made president, my inauguration was the first conference. I know some of you came. And it was the first conference, wasn't it, that was done at the new arena in Liverpool. And though Tom was insistent he would get that machine brought for me, and it came from the museum where it lives now in Edinburgh, and it was brought to Liverpool. And that touched my heart. I didn't know it was coming. And he was the most nice man you could ever meet. And sadly he died in 2019. But I felt very honoured. We became really good friends. And it was great. A phone would ring in my house at night and I'd pick it up and he'd be there and he'd be telling me all these stories. And one day I think I must write all that down before it's lost. But these guys, as I say, were really the true pioneers. And the early ultrasound machines, if you think of what I've got here, which is really quite slick, they only did static scans. You couldn't see anything moving. You couldn't see a baby moving or anything. It was like painting, if you watch videos of it. They put gel on, well not gel, it was olive oil I should say, and they'd had a thing and it would just go over. It's like painting. It was quite an art actually. And this is one of the first ones of a fetus that was done. So this apparently is the fetal head. I can get that. They say this is the placenta. I'm not sure about that. And that's amniotic fluid. I get that. And that's the mum's bladder. So I'll buy that too. Just not sure about the placenta. But it's not a bad image, and that was around 1960. But then we needed to get to real-time ultrasound. And these were the two guys who did this, John Wild and John Reed. And they built the first scanner in 1953. And they used it on a patient's breast to diagnose a breast malignancy. And this was a normal scan. And this one where you see the indentation here, that was said to be the cancer. And again, you can see the difference between normal and abnormal. But certainly we'd have a lot more information nowadays. And I just thought I'd just show you, because, and I've chosen fetuses because most people can recognise a fetus rather than a liver. And from left to right, this is 1985, head, spine, stomach. Then we get to 1990, we're starting to see a lot more detail in the baby. You can see ribs, you can see the spine in a lot more detail. And then by the time you get to 1995, we're starting to be able to see a lot more soft tissue detail. We can see the heart, you can see the aorta, you can see the spine. So you can really see that over a short period of time, ultrasound started to get to high resolution. And again, that's another baby that was done quite recently on one of the GE machines. And the detail of that baby, even like 4 years ago, wouldn't be there. It's just truly, truly remarkable how it's coming on. We also have the Doppler effect as well. I showed you that ovarian mass with all those blood vessels lit up in red. And the science behind that is said to go back to this guy, Christian Doppler. Again, we're back in the 1800s again. And he was an astrophysicist, and he thought that stars changed colour depending on whether they were going in one direction or another relative to other stars. And that was sort of the theory about the Doppler effect. And there's a lot of papers written currently about whether that really exists. I'm not going to bore you with that. What you'll be more familiar with is the Nino, when you get the ambulances tearing past you, or a fire engine, where you get the change in pitch as they go past. And that's what we use. My pal here has got buttons on it that I've highlighted there, that most scans I would do, I would always use Doppler. There's very rarely an occasion where I wouldn't use Doppler. And I always say to the trainees, and I know some of them are listening, that when you write a report, when you write down Doppler, it's got to the capital D, because it's the man's name, not a small d. Here's a Doppler, just to show the sort of what he was talking about with the stars. This is a right carotid artery in somebody's neck. And you can see red, it's a very patent artery, which is what you want it to be, and that's taking blood flow towards the head, to the brain. And then this is the jugular vein, which is taking blood in the opposite direction. Hence you get red for one direction and blue for another. We can do fancy stuff like this, where we can look at how the vessels, how the blood flow in the vessels behaving. I don't advocate this at all, but I think it's quite a pretty picture. This is a fetal umbilical cord done using colour Doppler. But again, it shows that you've got the umbilical artery where you've got blood flowing towards the baby, and you've got the umbilical vein with the blood going away from the baby towards back towards the mum. I just thought I'd show you some pathology. So again, this is a carotid artery, and it should look like this. It should be this wide, and if you look here, it's literally almost down to, well, less than a quarter of what it should be. And this area here is actually a thrombus. So this patient either has had a stroke, is at very serious risk of a stroke, and that would be flagged as an emergency. I'll say a little bit about 3 and 4D imaging. Again, those people who know me, so I'm a bit like, about this. I also had the honour of working with Stuart Campbell, Professor Stuart Campbell in London. He, again, was an obstetrician who was a big pioneer of ultrasound in medicine, and he published that picture of a baby smiling on 3D ultrasound in 2003, and it was on the BBC, and I was asked to do an interview after that picture was published for a tabloid newspaper who I won't name, and I explained to them about how the technology worked and how did we get to this picture. And when it was published, you might probably remember this, they said I built the scanner. I was like, no, I didn't. I ended up ringing up the BBC and saying, you need to set this record straight, and I had to ring Stuart Campbell and say, this isn't me, Stuart. I obviously wouldn't say anything like that. He took it in good spirits and it was all sorted out, but yeah. So you can now get what's called 3 and 4D live. This little tiddler was scanned 4 weeks ago using 4D live, and it's a little embryo, and you can see its head, see an arm, leg, other side of it. It's sitting quite happily in the cavity, and you can actually see its earbud and its eye socket starting to form. So things are coming on a lot. I have friends who have clinics who do this 3 and 4D scanning. You probably know people who may have been yourselves. And you can get some really cute images that actually really do look like babies as they're born. If somebody comes to me asking about this, I will always say to them, wait until sort of like after 30 weeks when the babies have got a bit more fat on them, because this is a baby at 22, 24 weeks. And without being disrespectful to that baby, they look a bit like aliens. And I've seen firsthand that have a very negative effect on the mum and the bonding of the baby. They go like, oh my God, what is it going to look like when it comes out? So I'm a big advocate for waiting. And this was a baby from last week, and I will thank my friend Nikki, who's also online, for sending me that picture to use. That was a baby at 30 odd weeks last week in their clinic, sticking its tongue out. That's actually prompts me to say that there's a lot of work being done on this about fetal behaviour, because if babies pull faces, they yawn, they stick their tongue out and everything, that can be a sign that the baby's quite healthy. And Stuart Campbell first started to think about, if it's not doing this, is this baby at risk, and do we need to start doing other things and thinking about getting the baby out? Sometimes we use these imaging to try and counsel parents. This little baby has got a facial cleft. You can see them on the standard black and white grayscale imaging, but that's quite hard for a parent. And we have used them a lot to show the parents what the baby will look like and to help them understand the surgery and what's going to happen afterwards. So there is a diagnostic use for this as well. Well, I'm not so sure, 3D imaging in sort of like what I would call general medicine, so in the abdomen, not really taken off. I'd tell you that was a gallstone on the right. I didn't need the picture on the left, which is a 3D, to tell me it was a gallstone. So I sit on the fence with that. And the other thing that we're not doing very well in this country is I worked in Europe for a bit. As Claire said, I worked for the European Society. And in Europe, when they're doing liver scans, for example, using ultrasound, they inject patients with a contrast agent. That's happened here. So this is a standard liver scan. This is the liver after it's been injected. Not the liver, the blood. The patient's been injected and it's got to the liver. And these lesions here, you can see a lot more clearly here. We don't use it in the NHS, we use it very rarely. It's costly. But I wrote that book with Christian Dietrich. And when I was out working with him when we were doing this, he was going, oh, you lot in the UK, you need to get on this, CS, as it's called, bandwagon. And they said, well, you're not going to get it in the NHS. The difference is, all their work is done privately. And so they can charge the patients for using contrast and things. So even now, we're really criticised in Europe that we're not as far forward as we should be. And I just thought I'd finish this bit by just briefly mentioning about what technologies are coming down the line, including AI. One is like fly-through technology. Does anybody ever remember a film called Fantastic Voyage, where they injected some kind of little spaceship thing, and it went all around the body through the different blood vessels? This is a bit like that. So this is a liver, and that's a hepatic vein in the liver. And the ultrasound has been able to almost like climb in to the hepatic vein. So you're now here in the hepatic vein, and you can go down it. So I can walk down the hepatic vein and other blood vessels as well. It's really quite remarkable. But at the moment, is it useful clinically? Well, it's useful a bit for arteries where you might have thrombus in them, and patients are at risk, as I say. But I'm not so sure about the hepatic vein, but it's a nice picture. Where else are we going with ultrasound? Well, there's machines now being built with AI. I just recently come back from Vienna, from the European Congress. I was asked to go out and speak there. And everywhere you turned was AI this, AI that. And one of the companies is currently marketing this machine, which has allegedly been trained on 2 billion annotated images using AI. And what they're saying is, you don't need somebody like me. To measure anything. Write liver on the screen. It will place a Doppler on the screen for me, and they claim all of that happens with 99% accuracy. And I went to a talk, and there was somebody doing a demonstration on the stand, and they were showing these videos of how much quicker it is if AI does all of this and not me, for example. And they reckoned that we would get maybe 5 or 6 more patients a day done by using AI. And I wasn't convinced, because it's not as easy as that. To do these things and do them properly requires a high level of training. And I couldn't get to the bottom of how good the AI actually was. I wasn't convinced about its 99% accuracy, I have to say. But I get in the NHS that if people get wind of that kind of technology, that's where we'll be going, because you'll be able to do more scans in a day. And that will be where we'll be driven, isn't it, in terms of solving our workforce crisis. So that's what the AI can do. As I say, it can measure, so you don't need me to measure this baby, and you don't need me to put the Doppler on, it does it itself. So a few headlines from ultrasound, my career. So as Claire said, I was with Venus and with EFSON, and I have done a number of other bits. One is I worked at Chester Zoo. I was asked to go in and scan 2 chimps. One was called Kate, and she had jaundice. And when I got there, Niall, who you might see on the telly, said, somebody must hate you, Julie, because these are some of the most dangerous animals in this zoo. I was like, oh, great, thanks. Anyway, the long and short of the story is the chimp is anaesthetised. It's done in the back of the chimp house, if you know the chimp house at Chester Zoo. She's lying on hay bales. There's various vets around with anaesthetists. And then they said, right, it's safe now, you can come in. Because these are really quite nasty animals, although I do love chimps. So I go in with my famous ultrasound machine in tow, kneel on the floor in my overalls and my wellies, and I had a rep with me from a company. And what I hadn't realised at the time was that there were these laser lights shining, these red laser lights shining, And the rep said to me, some people would pay good money, Julie, to see you on your hands and knees in the back of the chimp house with rifles trained on you. And I went, I didn't realise, and the vet said, the keepers had the rifles because if they didn't get the gas levels for the chimp right and it woke up, you wouldn't have time to get everybody out. So they would shoot it. But it was a good outcome for Kate because we managed to find that she had no cancer, she had an obstructive jaundice, and we managed to persuade a gastrosurgeon from Liverpool to come to the zoo and help at Leahurst and take that out, and she recovered really well from that jaundice. I've done a lot of telework, that was me with short hair a while back, and this was the Great British Diet Experiment with Chris Van Tullochen, and I got this message from Angela Cross afterwards, who some of you know, who sent me that, and that's on my Facebook page. And I was thinking, well, actually, I hope my spelling's good because I'm president of Bemis and I'll lose my job if it's not. You have these mad moments in your life as well when I thought, well, one day I'll write a book. And I did. And a lot of gin and tonics and a few glasses of wine later, that we produced that book with some of my really close colleagues. My children don't allow it to be out in the house because they don't want their friends to see it because they think it's rude. They did make me take sexual and reproductive health out of the title, and we got rid of the first part of it, which went down marginally better, but it's not allowed out. It's in a cupboard out the way. Hands up if you support Liverpool. So I did a spell working at Liverpool, and I know some of you know this already. I worked on the medical team on and off for 7 years and doing some research there. When I first started, didn't really know who any of the players were, and I'm not breaking confidence here. I'm allowed to do this. And this young man came into the medical room at Melwood. Who is it? Torres. Comes in, sliders, dressing gown, shorts, lays down because he's hurt his hamstring. And again, I had a rep with me because we had a nice piece of equipment who all supported Liverpool, and I said, you mustn't say anything, you behave completely professionally, you don't ask for any autographs or anything, no pictures. Right, Julie, I'm with you. Anyway, he wrote on the screen, the ultrasound screen, this is Torres, and I went, and? Anyway, when he got off the bed, he said to me, very nicely, and he wasn't being, arrogant, he said, you don't know me, do you? And I went, I'm really sorry, I know I can see now your name. And he said, well, let's do a reverse selfie. So he put it on his Facebook page because usually people ask him for a selfie. So we did this selfie in reverse because I didn't know who he was. I've never to this day lived that down. Anybody who's, when it's on the telly, I'll often get a message going, oh, what about Torres? Anyway, let's move on, nearly there. So talking a little bit about CT, again, not my bag, but you can see here, this guy, again, an Englishman, Hounsfield, electrical engineer, and he won a Nobel Prize, he was really the first advocate of building a CT scanner. And again, I wonder how these people think about it. I was asking AI to draw some pictures for me as I was doing this, and I said, how did Hounsfield, what would Hounsfield look like when he was thinking about building a CT scanner, and it made that picture? How can I do this? That's not Hounsfield, obviously. But that quote is from one of his things, and he said, I want to reconstruct a 3D picture of a box by imaging it in a series of slices. How do you think about something like that? That's just fabulous, absolutely fabulous. And CT scanning really growing like topsy again. At the moment, roughly about 10%, but the medphysics colleagues say it does give about 40% of the radiation dose. So it's quite a high dose of radiation in a CT scan. And so we're very careful about that, and we go back to that whole risk-benefit thing. I was hoping Chris Rice might have been here because he thought he was being funny in sending me this. Chris is a colleague of ours at Edgehill, and he sent me this on a Sunday about this is what a scanner looks like inside. But it doesn't, it looks a bit more like that, and you put the patient through the scanner, and it produces all sorts of wonderful images. So that's a lung scan, and it can do all sorts of fancy things nowadays. So this is a young guy, came off his motorbike and has got blunt force trauma to his chest, and this is a 3D reconstruction, and you can see his spine and his ribs and his scapula, and he's got quite a number of rib injuries, and he also had some quite serious damage to his chest from the ribs penetrating into his lungs. And I also wanted to mention this about CT scanning because in the Northwest, one of our colleagues who worked with us in the Imaging Academy early on, Dr. Sue Kern, is a radiologist at Preston, and you may have watched the programme Cause of Death. And the Cause of Death programme uses a lot of CT post-mortem. Obviously, traditional post-mortems are very invasive. And Sue and the guy on the left, who's been at Edge Hill and done a lecture for us, he's James Aidley, the senior Lancashire coroner, have come up with a strategy, and Tom will know all about this. And they are the leaders in CT post-mortem in the country. And that's just quite remarkable, and it's had a massive impact on a lot of patients and their families. So yeah, hats off to Sue and James for that. MR scanning was never my thing. It's a bit too clever in the physics for me. I like my little ultrasound. And this guy, Raymond Damadian, who was a US physicist and scientist, thought, again, another one of these light bulb moments, we need a non-invasive way of scanning the body that doesn't use x-rays. And he had this notion, and he built all these coils, and that was the first MR scanner. He was really proud of it, and quite understandably, until trying to persuade somebody to go in it. Nobody would. So he went in it. So on he jumps, and what happened? No picture. And there was no picture because they thought, well, it maybe was too big. So they managed to find, and it's described in the paper as a svelte student from his team, and put them in there and got the first MR picture. Again, quite remarkable. And then back to England, another Nobel Prize here for MR from the University of Nottingham, where they really took MR imaging forward. This is my level of understanding of MR, I'm afraid. You know, it's something to do with magnets and something to do with spinning or flipping protons. That's about me, really. I could never understand it. Diane and I used to work with Professor Graham Whitehouse in Liverpool, who was one of the leaders, wasn't he, in MRI in the country. And I could never get it, but he couldn't get ultrasound. So, you know, he would always do MRI, I would do ultrasound, and that was it. We just kept our two worlds apart. But I always used to say to him, is it safe? Surely it can't be safe or normal to flip your protons around like this. And he was like, oh no, it's going to be all right. And actually it's been used, hasn't it, for donkey's years now, and they've never again found any serious effects from it. And I mention Graham here because not only did he do a lot of work on MR, but he really was a trailblazer, wasn't he, Diane, in this particular field, and wrote loads of papers. So again, Liverpool. Something that we also used to get, this really does make me laugh, when Diane and I used to look after various degrees, and you have to do it, some of them had to do dissertations in radiography, and it was when they did the dissertations on a disc, and you'd have a submission date, and then they'd come to us going, I can't submit. They're like, why can't you submit? Well, I've been near the MR scanner with my disc. Like, really? So we tested it, didn't we, in the Marriott Centre in Liverpool. It was complete rubbish. After that, nobody ever got an extension for claiming that they'd put their dissertation near an MR scanner. Not as daft as we look, are we, Dan? This is serious here, because I know that we've got online this lovely young lady and her husband and her daughter and their parents, who are dear friends of mine. And this is Laura, so hi to Laura and Dan. And Laura, when she was pregnant a few years ago with little Sienna there, who's 3, was diagnosed with a brain tumour. Said she'd got a high-grade glioblastoma and was said not going to be alive for very long. When we first opened the Imaging Academy here at Edge Hill, some of you will have heard Laura. She's obviously still here. She's an amazing advocate for the Imaging Academy, and we can't thank her enough. She does so much work for brain cancer research. Where she gets her energy from, I don't know. Yeah, she and Dan opened the Imaging Academy for us, and we still do a lot of work with them. And as I say, she's a great supporter. So thank you, as always, to them. Now, I'm just going to briefly skip forward in time now. We talked about film, didn't we, for X-rays. We now need to get to the end of that bit. that story. And none of it's filmed nowadays. It's all computerised, digital, whatever you want to call it. No processors, no film. And that has its advantages because you're not wasting things. You're using things that are reusable. It's quite sustainable. You can play around with the images without repeating them. Lower radiation doses and so on. And it's not exploiting the depleting amount of silver that used to happen in the days of film. So nowadays we don't have that. What we have, and I've got AI to draw this. I asked it what would an early computed radiograph look like, and that's what it came up with. So no more film bags, thank goodness. Those of you that had to carry them around, and if there were a lot of them, they were really heavy. Nowadays we have packs, picture archiving and comm system, and they're really quite good. It links everything together throughout the imaging department and in the hospital, and things can be sent externally. So it's always described as improved connectivity. It's very efficient. When it works properly, it's very efficient. And you can get the images anywhere and any time. To say some of our radiology colleagues love that because they don't even have to get out of bed because they can have a workstation in their house and they can report from home. But that's, in all seriousness, is better for the patients because you want the reports to be done in a timely manner so that it can have a positive influence on somebody's management. We talk a lot, we're directed a lot more about not so much patient outcomes these days, but how many times a week do we hear what's the productivity? How are you going to improve the productivity? That's all we're asked, isn't it, at the moment? A lot about that. But really, we do this because what we want is patient outcomes to be better. I briefly wanted to touch on contrast media. Many of you will be familiar, as I showed you, with barium swallows, meals, enemas. So barium's been used a lot for a long time, so here's a barium swallow. But in the early days, they used some fairly horrendous contrast agents, one of which was lipiodol, and they introduced it into the spine. And it was, if you ever see any pictures of it, it was brutal. They used to spin patients round on chairs and everything. Yeah, it was horrible. But nowadays, things have got a lot better. You can see here, following injection of a more modern contrast agent. This was in the 1980s, they're even better. So this is an X-ray of somebody's kidneys, so it's called an IVU, an IVP, and this is their bladder, and there's a bladder lesion here. This is part of the biliary tract in the liver, and that's the gallbladder, and that's somebody's put a huge needle into that area and fill this up to give what's called a cholangiogram. So even in the 1980s, you could get some really good diagnostic pictures, but what they're often referred to as dyes, but we always say, please don't ever say dye, because you mentioned dye in front of the patient. It's not a good association. Things got a lot better. We now have very fancy injector pumps, so gone are the days when you had to try and whack something in by hand, where you've got to have really good muscles. The pumps do it for us. And you can get contrast for CT, and people deliver loads of talks on this, so we can only touch the surface. So that's an old CT brain, no contrast, and after contrast where you can see these lesions, an NMR scanner, and this is brain, and after giving the contrast you can kind of see here there's a defect, but it's much more noticeable on that image after contrast. I can't finish the clinical story without mentioning interventional radiology again. And in the early days of these sort of treatments, it was really just angiography, which was you put something in and look at the blood vessels, and the rooms weren't called interventional radiology or interventional theatre, they were often called specials. And that was the first angiogram that was done in 1896, where somebody thought of injecting contrast into a hand. And that is actually quite an amazing image, I think. This guy is thought to be one of the first pioneers of interventional radiology because he recognised that there was a potential for using catheters for performing surgery within blood vessels. And we've come a long way. In the early days, in the 1970s, it was really very much confined to arteries, veins, and a bit of the lymphatic system. That was kind of as far as it went. And you could look for things like tumour blood supply. You could map out vessels, and it was used a bit for bleeding in the gut, for pulmonary embolus, and for DVTs in the leg. and I mentioned the limb system. This is an old, what's called lymphogram. Used to put a needle into the toes. Again, it apparently took quite a long time to do this, but you can see the lymphatic vessels here. Don't do that kind of thing nowadays. This was one of the first angiograms that was done of the brain, and it's of the sort of left internal carotid artery. You can see this big bulbous thing here, which was actually an aneurysm, and obviously they run the risk of bleeding. But nowadays, this is much more like we have. So, you know, thanks to Siemens, when we're in Vienna, they have a big van which has one of these in it. So you might see them, they're off on the roads around here and moving between hospital sites, not just Siemens, there are other companies. But I found this quote from the Royal College of Radiologists about what is an interventional radiologist, because we're doing a piece of research work on this currently, on this sort of setup in the Northwest. And they do talk about them being life-saving treatments that are much less invasive than sort of open surgery. But the key difference I've noticed since I first started is in our days of intervention at Salford, we'd just do it in the radiology department. You didn't really interact with the rest of the team. Nowadays, it's a big multidisciplinary team approach, and it's kind of like a theatre setup. And things have really moved on, and the patient care has improved. The equipment's improved. These are the catheters. They're very small things that you put into the vessels. They all have different shapes depending on which vessel you want to go into. You can also put these in, which are coils, embolization coils. So if you want to try and stop bleeding, you can put these coils in. And just an example of that. So this is a heart, and here you've got some abnormal blood vessels in this area, and they embolized it. And can you see on the right, they've gone? And that was done using the coils. Now I'm going to finish, I hate to finish on a political note, but I will have a bit more, a funny story to end on. I mentioned that, that we've got some significant workforce challenges in this country. We are at the moment about 30%, 32% shortfall in the number of radiologists in the country. And 7 out of 10 of our clinical directors in the country said there are not enough radiologists to maintain a safe level of patient care. And from the College of Radiographers, the Society and College of Radiographers currently sitting around about a 12, isn't it, Tom, percentage vacancy rate. And so if you put those together, we've got a really massive, massive problem, and that's without the issues I've mentioned about sonographers. Coupled with that, we've got an increase in demand, particularly for things like ultrasound and CT and MR. And in 2023, the growth was 11%, but that wasn't matched by the workforce, hence this. You know, we can't keep being asked to do scans and not have anybody to actually do them and to report them. It's not a sustainable model. But we get hammered, I think is a fair statement. In 2023, only one hospital in the country met the reporting target. That's actually looking at the images, writing a report, getting it back to the referring clinician, one hospital out of how many in England. We're always being told the images are not being reported in a timely enough manner for timely intervention in a patient. So, you know, if you have a scan today, it needs to be reported quickly so that they can decide how to manage the patient. Sadly, there were best part of 750,000 in 2023 patients who waited more than 4 weeks either for a scan, and in some cases much more than 6 weeks for the actual report to be done. And again, that's a lot of what we deal with on a day-to-day basis. And the Royal College of Radiologists census asked the clinical imaging directors, how are you going to manage this? So we get now a lot of what we call outsourcing. I'm not going to talk about insourcing, just keep it simple and talk about outsourcing. So you've got this bank of images that are digital and they need to be reported. They can get sent out to an external organisation, maybe even in another country, because some of them do go to other countries, to be reported. Then they come back into the NHS. And in 2023, there was £276 million spent on alternate ways of image reporting. And that would have funded that number of additional consultants, nearly 2,000. and over another 1,500 registrars. So that is something, again, that we are trying to deal with, but it's not easy. And this is where they say, and I'm at the end now, is AI the answer? We see on the telly, don't we, every day, they call it trolley care, I think that's an outrageous statement. But patients are blocked on corridors, and NHS Transformation put out that statement, AI has the potential to transform the prevention, early detection and treatment of diseases so that we can get better and faster access for patients. And they do this because you can train AI to look at images and you can get computer-aided diagnosis. But also what we saw in Vienna was a lot of image production. So a radiographer, for example, would normally, if they're doing a chest x-ray, they greet the patient, they set them up for the x-ray, it's all done by a lot of highly trained positioning, and you then deal with the x-ray equipment and choose the exposure, press a button, blah, blah, blah. And it was all automated. They had AI moving the x-ray machine around and doing everything, which was fine on a normal patient, but we had to play with it. And if you've got a patient who is very sick and they're like this, you know, or like this, it didn't work. So it's fine if somebody's cooperative and ambulant, but it wasn't so fine when we tested it a bit further. The other thing that was being pushed a lot is about workload optimisation. So using AI to plan lists, CT list, ultrasound list, MR, and monitoring the patients as they go through and trying to say that, you know, it will be a lot more efficient than our admin clerical staff who do that for us currently. So it's kind of a bit watch this space. So we had a meeting Tuesday morning and we were thinking about how might AI help the NHS. And we were talking about CT head scans, and there is the potential maybe for AI, maybe particularly overnight when these things are often coming into the department, could AI actually do kind of what would be the first look? Normal, abnormal. And if it was abnormal, then it might go for human reporting, whether that be a CT head reporter, radiographer or a radiologist. So that's something that we're talking about locally. The Preston team, again, they lead on, some of them lead on the lung cancer screening programme. And again, AI is being used in that currently. And it can identify lung lesions. Some of the radiologists are quite cynical about it. As you can imagine, you know, it's a bit of a territorial turf war at times when something like this comes out. I've seen it many a time. But I'm kind of with them because it's got to be proven. And at the moment, I don't think there's the evidence base to say that, you know, 100% of the time or with a high degree of accuracy, AI could actually do the first pass in the lung screening programme reliably or in any other sort of programme. It raises ethical issues. What if AI gets it wrong? Who's responsible? A lot more debates to be had on that currently. So yeah, as I say, it was everywhere, but it's not proven. And I'm a big advocate, as many of you, that there needs to be an evidence base. And it got that wrong. What's the deliberate mistake? It's just got AI and the letter I, radiology. It didn't do in. I asked it about the evidence base in radiology, and it got that wrong. So what's going to happen, you know, if it starts looking at images? And just to finish, just think back to the start of tonight, you know, we're in this AI world, there's this complete obsession with it. Let's run with it. But go back to the beginning, they did that with x-rays, and look what happened. So, you know, I think there's an element of caution to be had here. Those of you that know me well know I'm an absolute car maniac. I love F1. It's a bit like that with, I feel, AI at the moment. You're like on the starting grid of the F1, and they're all going to go like this, and I have a horrible feeling we're going to go back to the Royal Courts of Justice in some situations, and that will cost the NHS a lot of money. It's got to be done in a measured way, and it's got to be done based on a firm evidence base, because every patient life matters. That's why we do what we do. Just to finish, I'll just go back to the Academy. We're very proud this week. We've just launched our new learning platform, which we've developed with the London Imaging Academy. If you have it, if you have an NHS email, You can go into this, and it's got a whole host of resources for loads of members of staff in the imaging department, whether you're a radiographer, sonographer, CT, MR, physics, you name it, it's there. And I know quite a lot of you will have had a look at it. So please spread the word amongst your imaging colleagues. And it's being pushed very hard on our social media and with all our networks and the society and college, etc. So just to finish, what will the imaging workforce of the future look like? So we've kind of alluded to the fact that, we might not have radiologists, we'll have a first pass maybe by AI. This has made me smile. This was in Vienna. I took that picture of that little robot. I went to the stand and I said to this really pleasant European lady who was non-clinical, what are you going to do with this? And she said, well, it can care for the patients in the imaging department. I was like, okay. So we pushed this. I was with Linda Williams, who some of you will know. So we were pushing this a bit further. I said, well, in what kind of way? And she said, well, it could go to the waiting room, shout the patient, and then the patient will follow the robot to the changing room, and it will tell them what to do. Get undressed, put you down, and blah, blah, blah. Then it will bring them to the imaging room. I had this horrible vision going on in my head that we might be in the department in Liverpool and there'll be all these robots going around with patients following. But she was serious, absolutely serious. And I was like, oh dear, where's that going? So I asked AI what an imaging department would look like if there were robots, and that's what it drew. Actually, that's not bad. But I can assure you in the northwest of England, patients won't be following robots around the department, will they, ladies? Not in our lifetime anyway. But it does bring a serious note about that, because it's changing, and AI, whether we like it or not, is coming. So we're now going to have to look at how we train people, aren't we? In all seriousness, the degree programmes for radiographers will have to change, the radiology training, the sonographer, CT, everything is going to have to change. So over the next few years, I think we're going to be a bit busy, aren't we, with this kind of stuff. So I just want to thank you again, and to finish by saying, it's lovely that so many people have made the effort to come, and thank you for coming. I do really appreciate it, and I wanted to dedicate this obviously to Tom, because he was my pal, and I loved him dearly, but also to my dear friend Christine, who was a radiographer who trained with me in Lancaster, she went to work at Preston, and sadly she was killed at Hillsborough. So whenever I do any talk, I will always dedicate it to those two wonderful people. So thank you very much. I hope that was interesting for you.